Welcome, everybody, back to Health, Biz, and Politics. It's Wednesday, and this time I'm coming to you from Turkey. We have a great show for you today. It is 7 o'clock my time, 12 o'clock your time, or depending on where you are and where our guest is. If you're new to the channel, you can find information about who's upcoming on the programs, what's happening, and hopefully you see it. And it is your-mp.com, and you can go over to the tabs, click on your media hub, and this will bring you to our site and the seminars, the webinars we have regularly for Wednesday and Thursday. You will also notice the Buy Me a Coffee, buy us a coffee, thank you. This is a volunteer effort. We try really hard to bring you the best speakers out there on the topics that are important to you, especially in the healthcare field. But you can look down, see who's coming, and down at the bottom are our social media channels, BitChute and Brighteon, YouTube generally for the Wednesday show, and Rumble. Thursday's a little more controversial, and most of our Thursday shows do not make it to YouTube. So I think that's good, a good start. And with that, let me stop the screen share. And Charles, take it away.
Sure. So today's topic is consistent with a lot of direct primary care doctors we've platformed on the show over our 5-year existence, broadcasting every single week of the year except holidays. But today is a little different in that it introduces the whole picture for direct payment subscription care with primary care doctors, because Donovan's organization, the American College of Private Physicians, represents both DPCs and old school concierge practices, which have catered up till now to more wealthy families who can afford the fees that they charge monthly. A lot of folks are pretty high on DPC because it has democratized the practice with their monthly subscription payments that are below $100 a month, maybe around 100 or more for families. But I won't tell you everything about him because Donovan is here to do that. It was probably more than a couple of years ago when their founder, Thomas Legrelius, presented from his practice in Torrance, Los Angeles, California. And so we're very excited to have Donovan return. He also runs Kona Consulting. I assume Kona has something to do with Hawaii, or maybe it doesn't. He'll tell us. And at his website that he'll show, ACPP, there is a nice page there on all these consulting practices on helping doctors ramp up for independence. One of the products we promote at Freedom Hub, the Wow Cash Appointments app, is there to help doctors get cash payments on a fee-for-service basis or a monthly subscription basis. But a lot of doctors are scared to go independent because they've grown comfortable as employees in hospital systems. And, they've become addicted to the hamster wheel of chasing insurance reimbursement and accepting the standards imposed for being members of a network or an insurance company. So this is an uphill battle. But the patients who belong to these monthly subscription memberships love it and never leave it, unless it's some, I'm sure it happens occasionally, but these doctors eventually have to close their practices to new patients because they have, 500-600 patients and they don't need any more. We'll ask a lot of good questions after his presentation on, to what extent does it accommodate fee for service, not just monthly payments? How do some of these doctors still rely on insurance reimbursement for hybrid practices? To what extent does the time gained for the patient lead indirectly or directly to a more integrated practice, which we're very keen on at Freedom Hub? How can we help with the other entrepreneurial ventures that some of us are engaged in, creating the cash patients that these doctors need to really grow their practices? And with that, Donovan, the floor is yours, sir. And then everyone knows we'll rejoin later for Q&A.
Great. Thanks for everyone attending and welcoming to the meeting. I really appreciate it. And I'm hoping I can add some insight, add some clarity, and address anyone's questions that may exist. I'll just start with a brief little summary of American College of Private Physicians. It's simply an organization that supports concierge and direct primary care doctors. We give its camaraderie amongst other physicians. We route patients to them. So we also help patients find a doctor. We provide support services and a series of other things that empower the doctors to migrate into one of these platforms, such as DPC or concierge, but also to keep the practice going, keep everything connected, and stay cutting edge, which those doctors that pioneer into this kind of model typically are pretty cutting edge already. So one thing that I can highlight real briefly on the website, we're physician led. There's a board that runs the whole show. We have services that doctors can connect to provide with everything they need in their infrastructure. The phone system, marketing, you name it, anything they need to operate. We provide it all at a collective economies of scale pricing so that it's all low cost for them. And it's also highly tuned towards concierge or direct primary care. We do all this through membership. Membership is either bronze, silver, gold, $100, $500, or $1,000 a year. So very cheap as far as memberships go. And we help with cross coverage and a series of other things. Patients also use us to find a doctor. We're a reference link for a lot of validations of credentials and legitimacy in the direct primary care and concierge space. That said, let's talk broadly about concierge and direct primary care medicine. You guys are entirely correct. The direct primary care trend is very high right now. There's lots of people transitioning into this model, and there's lots of interesting versions of it that previously didn't exist. It used to just be a subscription model, but now you're getting all sorts of very customized versions. You're getting a functional medicine version. You're getting a weight loss version. You're getting one that just takes care of inner city New York Jewish communities, and some that just take care of housewives, or house husbands. You've got all sorts of different versions, and the different flavors is making the community much better overall. So you're really getting kind of not just a doctor that's customizing everything for you, but you're also getting a clinic that's kind of further helping your identity or your unique problems or whatever there may lies in. As far as the concierge space goes, that trend is slowing down a little bit, but concierge and direct primary care, it's really just a vernacular difference. Like, it's syntax. They are essentially the same mechanically. Concierge clinic, for instance, the average census, the total number of patients they have, is around 300 to 350. The average annual membership fee is about $2,500. So, I mean, just with $2,500 and a census of 300 patients, you've got $750,000 a year per doctor for income. Your overhead is much less. You're not paying 5% for billing. You're not paying to have care coordinators and a series of this other typical commercial insurance or even participating in Medicare and Medicaid requirements that require you to have this huge team with a large overhead. A doctor and a medical assistant really can build and operate one of these clinics quite well, especially with the tools that ACPP provides to its members. So that's $750,000. Your overhead on that could be as low as 10%, 20%. Like, it's very manageable to have a well-run company on that system. Of course, not everyone has an overhead that low. You could have high rent. You could own the building and pay yourself, higher rent depending on taxes. There's lots of different things. Direct primary care, on the other hand, charges $200 and under for some of their monthly subscriptions. So if you maintain the same census, let's say 300, if someone it'd be the same price as the concierge model if someone paid $208 a month, which is very small as far as your health insurance is concerned. It's a financial benefit for everybody. That said, we have noticed direct primary care is going as low as $50 per month for these systems, for these models. Now, sometimes there's an argument and a perception that this is for luxury. This is a high-end thing. This is for the rich. In all countries, all developed countries that have universal health care, concierge and direct primary care still exists. It's a good model that works for everybody. In Canada, who America loves to compare themselves to, we could go on and on about the different metrics and success and waiting line. Irrelevant. Not going to talk about that. But in that model, people will still engage in direct primary care and concierge practices. And it is a public benefit for some to do so because it takes those people out of certain waiting lists. It takes those people out of certain encounters that would normally slow down a government-funded clinic or a mandated clinic. It benefits everybody. If a doctor wants to enter this model, right, so be it. But they can also hybridize and participate in both worlds. So we have a lot of concierge and direct primary care doctors that are still participating in Medicare shared savings programs because they typically spend less on their patients. Their patients typically don't go to the emergency room, and they typically don't need to refer them out to specialists because they're giving such in-depth, granular care, not just turn them and burn them encounters. They often get shared savings bonuses and quality bonuses through HEDIS measures. That's very common. And usually the MSSP provides those services. In a community mental health model or a life model, which is very common in certain states, participants in both programs can get a bunch of community benefits, or maybe they won't take funds from the community funded programs any longer. We've been seeing a large trend of people offering community-driven direct primary care groups. The New York City Jewish community example I gave, that's a real thing. We have we have multiple direct primary care members in New York City that are serving specifically a Jewish community or specifically another community. The community doesn't really matter. The fact is they're working through a specific community, whether it's through the church, through a school system, whatever. And they're aggregating resources. They're speaking the same language, using the same core tenets of practice and faith or cultural references or whatever is unique to that community. And they're providing more than those people would otherwise receive independently. They're providing urgent care type services. Sometimes it's treated like a normal clinic and it's funded by the church, by some grant, by some system. And it's really working well for people. We've learned through a long time that healthcare, if we take care of things in a preventive way, you can avoid millions of issues down the line. And early access is very uncommon. The trope that we need young people to participate in the Medicare and Medicaid and commercial insurance model to lower the cost for everybody else. Obviously, young people can't be in Medicare, but they can still contribute money to it. We need them in that system because they don't spend money because they don't have health issues. That trend and that awareness simply isn't being done in practice. Young people simply are not participating much in commercial insurance, even with all these wonderful acts that have been pushed to help them get involved in it. In the DPC and concierge space, instead of using things like Blue Cross Blue Shield or other kinds of systems, it's very common to see cost share programs. These are things like Mint, Sedera, Wow, there's tons of them. And in these models, it's a much lower rate. They require you usually to have a direct primary care or concierge doctor. So that's good business for you. They're pushing patients your way. And they just use a cost share model to share healthcare costs. In my own company, we once gave Blue Cross Blue Shield PPO Gold to every single employee. The average expense was $700 a month. It was insane. So expensive. And when we added up over the year, what was our total utilization? How much money did we spend on healthcare? We had a couple sick employees. We had an employee who had a child during that year. We had a bunch of things. Our total spend was like 4%, meaning as a company, I lit 96% of that money on fire every year. It was just thrown away. Moving to one of these other systems, we now have a program that is much lower cost. We've closer to a 60% utilization. There's fewer patients and less bureaucracy. So usually our staff has a better experience with their insurance rep, even though it's cost share, it's not insurance. And they're put up with a DPC or concierge doctor. So they get better healthcare. They feel more connected. We've partnered with a direct primary care in this particular region where I am, where the majority of our employees are. But our employees also travel the world. They've got tons of other connections with other doctors. They are extremely happy with their medical care. Whereas in the old space, they weren't. They were pretty dissatisfied. It took a long time to get an appointment. Impossible to talk to the doctor. We've all heard these things a million times over. It's a common complaint. With the new model, they can be on a beach in Thailand, say, I'm having a stomach ache. I think I may have eaten something. And they can text their doctor through a portal and get pretty quick results, if not immediate. And that doctor knows them very well because they're only taking care of 300 to 350 patients. It's very reasonable. It's just better care for everybody. As an employer, which in the American model, the employers are often expected to provide the health insurance and somehow give them access to medical care, which is a pretty crazy concept, right? Like we're not expected to give daycare or anything else. But nonetheless, that is a common trope in America. We spend less and we give far more to our employees by participating in this model. In doing so, we believe it, we drink the Kool-Aid, we promote it to our members, our clients of all sorts of different walks. Oftentimes people think of concierge and direct primary care as a result of burnout, as a result of just being sick of this health insurance model here in the States. But it doesn't have to be a result of a negative. It could just as well be the goal that they want to go up and practice this kind of model, good quality personal healthcare. We're facing a doctor shortage. We already have a mid-level shortage as well. But unless the healthcare industry changes as a whole, this is the best way for doctors to protect themselves to enter into these kinds of models. And I know it can be scary. Totally get that. There are some predatory vendors out there that help convert, and there's some odd practices on that. All this help, all these questions on what's good, what's bad, what should I do, would this work in my clinic? That's stuff ACPP provides, the American College of Private Physicians. We help provide guidance and like, hey, this is what some of our doctors do. We're not just promoting something. Here's their cell phone, call them up, ask them, talk to them doctor to doctor. This is how it worked for me. This is what I did. This is what I wish I would have done. This is what I learned over years of practice. We help people convert and stay that way. We help people with existing practices maintain them. We help practices that maybe have some very unfortunate sudden circumstance happen, keep their practice open and stay afloat. We help them broker deals between different groups. We've had one that retired recently. We found another doctor that took it over. It's a really good safety net for everybody to have. In the hospital world, that all that safety net is provided in a very predatory way by the administrators and suits at the top. Like it provides no benefit to the doctor at all. In our model, we are built by doctors for doctors. We keep everyone going, and it's very low cost. So as far as a better access for patients is concerned, and the political landscape of healthcare and everything else, it just seems clear to me that even if you're in good health and you don't visit the doctor a lot, you don't want to wait in line, you don't want to go through the awful phone call experience to even book an appointment or anything like that, why not consider the concierge and direct primary care model? It actually isn't a super expensive, luxurious thing as it may appear to be. Don't be wrong. There are concierge doctors that charge $8,000 a month. There are some that charge $1,000 a year. There are some that, there's some DPC clinics that charge $50 per patient per month. There's some that charge $300. Any model is feasible. You can find one that works for you. And it doesn't have to be limited by a scope of taxonomy anymore. We've got gastroenterologists who are practicing concierge medicine. We've got emergency doctors that are doing it as well. We've got some that incorporate behavioral health into their models. We've got some that put out meal subscriptions and do monthly workout plans, live streaming with their members. We've got some that hand out little Oura rings like this so that the doctor can centralize and track your performance of like, are you moving enough? Are you doing something? You can get what you want in this model, but you definitely don't get what you want in the standard commercial model. You get what the insurance company pays doctors, which in their mind are overpaid note takers, to do for you. You might get a good doctor, you might get some good help with that, but the doctor is limited in their practice by what insurance will compensate them for. And though it may seem like a moral, reasonable thing to expect the doctor to just see maybe 15 patients a day, spend some time with them, give good care. Yeah, I agree. That should be the way it is. But if you just look at the cost of business and their ability to operate, you can easily see that they have to see a lot of patients, no matter what. Even with the value-based reimbursement model, they still see a lot of patients just to stay afloat, to continue to provide you care. So in a concierge and DPC clinic, they're not limited to how many patients they have, what's their volume. Oftentimes, they might not see a patient for a little while because that patient doesn't need care. They might reach out to you proactively and say, hey, I noticed through this ring thing, you don't seem to be doing much movement lately. What's going on? But you get actual personalized healthcare. And this is nothing new. This is actually the way it used to be. Like the Wild West, when there was a village doctor, this is how they practice. This is actually an older model. It's just coming back. So that's a rant. Please throw some questions at me.
Yeah, let me, Charles, let me jump in a second. The old village doctors, I think, and going way back, focused a lot more on personal, like nutrition and health and herbs. And in fact, here in Turkey, where I am for the time being, I was in a pharmacy yesterday that was a plant medicine pharmacy, which I thought was pretty cool.
Mm-hmm.
Isn't that what we really want to move towards? Because a doctor just going from the insurance model, which is a sham, to a private practice, but doing the same thing using allopathic medicine and not bringing these other modalities in, right? Is going to be delivering the same care. So do you see that happening? That's one of my questions. Do you see that happening in the DPC concierge care movement? And or are you guys doing anything to promote that, to widen the toolbox for these docs?
Yeah, so we see that a lot. We do see a lot of specialization in allopathic, even sometimes going a little extreme in like the fully hippie version of medicine. But we see people going in another direction as well. We see some that are really hardcore, like pharmacy driven prescriptions. We're going to do an X-ray, we're going to do an MRI, we're going to track it. The thing is that you can find either option. You don't have to rely on what the insurance industry says. This is how you practice medicine. You can find a concierge or direct primary care on any end of that spectrum, sometimes in both. Obviously, there are some patients where just eating a really healthy diet is going to be good enough, and they're going to be living a good, long life if they do so. There are some where we have patients that have an extreme health condition, a status that needs a lot of intervention.
Sure.
There's both sides. And the thing is that the concierge and direct primary care community is generally more welcoming and happy to cross promote one another. Some might say, oh man, now that you've gotten in a car crash, now that you are homebound, you're in a wheelchair, you can't come into the clinic, you need telemedicine only visits, and you've got tons of complex medical issues. You might be better served by this doctor. But that's assuming that this doctor wouldn't naturally take care of that patient, which is probably what would happen.
Okay.
I'm just saying that there are multiple options, multiple versions in the space you can get, as opposed to the insurance model, which says this is how you practice medicine, like period.
Sure.
Breast cancer screenings at this age, this thing at that age, this thing every single year, ask these questions. Healthcare moves at a very slow rate. Our medical discoveries are not going to be implemented into common care for probably 30 years after they're discovered. We come up with things all the time, new discoveries, new medicines, new better ways to treat things, and it doesn't translate into the common primary care clinic.
Right.
There's no incentive to
Okay.
it. It's just turn and burn, do the same thing over and over again. Excellent question. Keep them coming.
Thanks. Charles.
Before I ask my question, if I can follow up on that one, the integrative aspects of this time. And time has been a theme with our DPC presenters over the years. And that is when there's no hamster wheel to get the patient in and out in 15 minutes, and then, find some diagnosis to get insurance reimbursement, that necessarily changes the doctor, which is kind of my favorite thing with these doctors who may not want to talk about how much more integrated they're becoming. Because when you have all this time with patients, we know the real epidemic in the country is chronic illness that affects now half the country. And prescriptions often fail to stem that endless epidemic. Do you ever have discussions about how the extra time for the patients? There's no rush. There's follow-ups to kind of figure out what's going on with you. These chronic illnesses are tough to diagnose and treat. Have you guys had many conversations about that dynamic that necessarily changes the art of doctoring? I mean, it returns the art of doctoring so much.
Oh, yeah, absolutely. I would say it takes a long time to break the habit of Dr. Clock is, on the phone for you. It takes a long time for doctors to go, wait a minute, I can take however much time I need with this patient. It also makes those visits extremely more valuable. I mean, there are, in the traditional medicine space, which wearing another hat with another company, we operate in quite a lot. We see that a lot of visits are, okay, we're going to have a conversation about this acute issue. Oh, you have to talk about something chronic? Better schedule another visit because I don't get reimbursed for that. Carry on. And you just chunk up a bunch of worthless visits. Whereas in a direct primary care or concierge, we can have the full conversation about everything you care about all in one. It can be a truly valuable conversation. Let's just take the metric earlier. I said the average concierge doctor charges $2,500 a year, and they have 300 patients, and that generates $750,000 from them, which is mostly profit, by the way, as far as EBITDA is concerned. That same model, $750,000, let's say that's what I want to make. I'm a doctor. And let's divide that by $100 an encounter, average reimbursement for a 99213 with a modifier and some other just average visits with the patient. And 280 working days a year, assuming you've got weekends and a little vacation, you would need to see a minimum of 26 patients per day, almost 27 patients per day, to earn that same revenue, which, by the way, is not mostly profit. It's mostly paid to your support staff. That's a hamster wheel, implicitly, just the numbers alone. Forget about the care, forget about what you might want to talk about, forget about a checklist of things to discuss with the patient per encounter. That's 27 patients per day versus 350 patients or 300 patients in that model, 280 working days. You could get away with seeing one patient per day. That's just the math of it. Of course, that's not how it may work in actual practice, but those numbers alone completely shift the dynamic of how care can be assessed. Not to mention a traditional primary care clinic, you don't fix acute issues, you don't fix chronic issues, you hear their concerns, you make a referral note, and you send it to somebody else to fix. And a concierge direct primary care, you're coming in, I'm working on behavioral health, I'm working on physical health, I'm doing some labs, I'm doing a full in-depth workup on you. I might recommend vegetables or something. I'm not a doctor, but in this example I was. But there's a lot of solutions we can provide, and we can spend time on them. A doctor can, instead of trying to keep up with their head underwater, figuring out how they're going to take care of you and just managing reports that come through as quickly as possible. Yep, refer to this. Yep, refer to that. Like, that's not great care. With this one, in a direct primary care concierge space, they're looking at my health profile that they generated and go, hey, I want Donovan to try this out. Maybe we should do that. It's proactive and well thought out care.
And I think with past DPCs, one of the new services they're getting into their clinics are online referral networks, so that instead of wasting your time with a specialist appointment, they can get these specialists on the phone or in some connective way right now to give a specialist opinion, saving you time and money. I'm not sure if you've heard much about that, Donovan, but
Yeah,
you want to comment on
there's
that?
lots of great programs like that. So yeah, the specialist works through the primary care to provide medical advice and recommendations and treatment plans. Unless, of course, it requires surgery, then it still does get referred out. But you instantly bridge a gap. One of the things in America we say about our healthcare is, well, you can get immediate care. There's no line compared to a lot of universal healthcare groups. That's not really true. We call them different things. We have a pre-op. You got to meet with this specialist. You got to meet this. You wait a month for this appointment, then another month for that appointment, and so on and so forth. With that model of working with specialists through this network, you can immediately eliminate those lines. I could see you. We determine there's a UTI issue. I get a urologist on the screen to review your note and give me some recommendations, and I can skip right to a really great treatment regimen, as opposed to UTI. I don't touch those. Refer them out, and that whole process could take months just to get a simple prescription that would fix it, or a simple allopathic solution or something else.
Don, you're next.
Yeah, so Charles was asking, we have an online multi-tenant environment that allows practitioners or experts to educate their clients in an online capability where they can add programs and classes and education and videos. We have workout programs, nutrition programs, and Charles was asking about the wearable side of it. And we integrate wearables, the Apple Watch, the Garmin, the Fitbit. We're in the process of finalizing Withings that does a blood pressure cuff and a weight scale. And all of that is done where a client logs in one time. They log into the application like Fitbit as an example, and then all of their data displays on their own personal profile on a constant basis to keep them up to date on everything from blood panel to DNA to their steps that they have in a day or their sleep. So it's all an automated process that's all weight labeled to the doctor or the medical practice. Charles just wanted me to mention how we're handling the wearable side.
That's awesome. And we're seeing a large trend with that. In the traditional medical space, remote patient monitoring, RPM, it's kind of a dirty word. It's a billable fee-for-service thing, and value-based care, it's shunned upon unless it's for the high acute, lots of issues. 1% of the patient population should receive it because we're trying to do cost containment the whole time, or maybe we're trying to make a mad grab for fee-for-service revenue. In the concierge and DPC world, it's totally different. It's used for what it should be. We want this data to give recommendations and healthcare insight on what's going on with our patients. And it's a wonderful thing that the systems that you mentioned, those are great because they can be purchased at Best Buy or any corner store. Those are widely available. There are vendors that do provide like very customized RPM equipment that gets deployed out, and you have to use their stuff, and it all integrates and it uses SIM card enabled stuff, and it's pretty fancy. You can do either model. They're both great. However, the way a concierge and DPC clinic would treat and look at that data is different than how a traditional medicine space would. It's more proactive. We've even seen some direct primary care and concierge clinics that make a game out of it with their whole patient population. Part of the deal is you sign up for this hardcore DPC or concierge space, and you're competing against all the patients. You're trying to see who can step more, who's got a better blood pressure. That works. You gamify it. People get really into it. But you can also just gamify against yourself. I feel pressure when I don't complete my steps every single day. And if I do less than I did the previous day, that's stressful.
Gamification is a big part of it, and in putting all of the challenges in where you can have different challenges each month for different types of topics as well. So we have challenges for caloric burn, and the next month might be for steps, and the next might be for sleep. And it's all very education driven and very interactive.
Don, you might want to consider the water bottles that have all that built in too.
I already have been working with one of them.
Good, yeah, I love it. It's I'm bad at drinking water, and this thing lights up and tells me, hey, drink water, darn it. My doctor will call me up and say, you're not drinking much water. So that's helpful. That's really helpful, valuable insight.
Yeah.
Michael.
Yeah, hi. Thanks for taking my question. This is something that's been interesting to me. So I'm a spine surgeon, but I was a physical therapist before I did this for a living. And my traditional practice was I was the spine guy, meaning primary care for spine pain in my region. And because I was a PT, I couldn't just let people leave. So I often treat, I spend time with patients to figure out their problems and send them away whether they need surgery or not. Is there a role for that in these models? I would think that, we've developed digital triage algorithms for patients to take, for the docs, hey, it's not an appropriate surgery referral. But I would think it would save everybody time and money and access to engage with direct primary care clinics or concierge, just have no real way on understanding how to approach those groups or practices. Because to me, with corporate practice of medicine across state lines, if I have a cell phone and a Wi-Fi contact, you should be able to contact me. Take my knowledge, apply it to your patient, and everybody should benefit from that. So to me, I think that's a model going forward. We don't have the workforce or bandwidth. The old model's dead, and it always will be dead. And so I'm wondering, what do you think that looks like, and how would you access that system?
We actually have some members and some groups that are doing what you just outlined. So a couple, let's segment it out. Are they close to you or not? Like if they're local, obviously that's a totally different way that you can treat and work with them. But let's assume they're not. There's the knowledge of proper spine care, physical therapy, just generally how to take care of yourself, that we can package up and make part of a program, part of a thing to monitor in concierge and direct primary care clinics. A lot of them don't spend much focus on that, but what the majority of the groups that work with us, at least, we encourage each year for them to pick a new thing. So there's a patient ladder. So this means new patient comes in, figure out everything that's going on with them, get them on a treatment regimen, make sure they're taken care of. Okay, year one of that patient, the basic general stuff is taken care of. Year two, let's focus on spine health. Year three, let's focus on behavioral health, whatever the case may be. They kind of pick a ladder to work through the patient with over the course of time to guarantee a full, well-rounded healthcare treatment. That's an obvious segment, very easy. It's education, it's, what your spine should look like, what your posture should look, things like that, very easy. The third and probably more tangible aspect that we use quite often with a lot of groups is we coordinate with imaging centers, or we even set up mobile imaging for various groups to do cash pay. All the regions where I take care of concierge clinics directly, me and our team, we have contracts with imaging centers where they'll do MRIs for $300, X-rays for $50, like unbelievably cheap, which is very reasonable for these imaging centers to do. The imaging is highway robbery in the medical system. It's offensive how much is charged. So what they do is part of an executive annual wellness visit, or maybe there's an acute reason they might do this. They get some imaging done and they partner up with a spine surgeon, with someone who specializes in MS, whatever the case may be. They send it to them for review. They get a treatment program, and either it's, we recommend you do this, or hey, you need surgery. This is what we're going to do, period. But it's a way of collaborating that care much better than a typical PCP and ortho referral pattern, which is, hey, I think there's a spine issue, take care of it. Surgery, let's go. It's not a very helpful system.
Right, it's broken. So
Totally. Yeah, we see that model though with not just the specialty you were describing, but we see it with all sorts of different things. And to Jim's point, we see all versions of it. So there's some that are for allergies. Yeah, we have allergists that can collaborate and work through these things. Great, fine. There's probably local allergists that can do it as well. And you can partner up with them to do a fee schedule that's reasonable for cash pay, or maybe it comes out of their annual fee with you. Then we also see some that are doing more allopathic recommendations, you know, let's do this, let's do that, eat this, eat that. Whatever version there is, you can find a clinic that believes and promotes that version. And even if you can't find a clinic that's close to you, if proximity is important, the doctor can spend so much time with you that they can customize the care plan for what you care about. If you want to go full on intervention, fine. They can recommend and encourage that. If you want to go full on preventative or allopathic approach, that can exist too. There's no limitations to the type of care that can be provided in the direct primary care and concierge route.
Charles? Thanks, Charles. Yeah.
Continuing to delay my question so I can follow up there. I love the vision inherent in this question, because you mentioned Canada, Donovan. I heard also that not only do they have access to DPCs and cash clinics in Canada, but a lot of them start their primary care with a chiropractor. And the chiropractor here in Williamsburg for the William & Mary football team is full service with PT, massage therapy. It's a great place to go. And I'm friends with Dr. Tinsley, DPC down the street here in Newport News. And it seems to me that building into that monthly fee, a PT person on staff of some sort would really make these things worth the money.
Oh yeah.
Is that idea percolating? Because to me, it's a no-brainer.
We've seen it rarely, but it does exist. We've seen some that incorporate PT right out the gate. And sometimes it's dependent on the patient and they happen to have a program in there. We have some where it's that's standard. You're doing it, you're doing yoga, you know, if you want to be a member of my DPC or concierge clinic, you're doing one of these things. We've seen some where you've got, there's one that specializes exclusively in diabetes, and there's a registered nurse who walks you through your diabetic care, how to take insulin measurements and things like that. They walk you through this stuff. We've seen lots of different versions with all those specialties, but in Eastern medicine, talking Vietnam, Cambodia, a lot of China, it's chiropractor driven as well. Like that's your entry point for a lot of care. And then from that, they might recommend you to see some other kind of specialist. But yeah, I've seen that. Because I'm not a doctor, I can't comment on the legitimacy or is that a reasonable, medically sound decision to follow. But I've seen it and it seems to be working quite well for a lot of people.
Let me jump in. Isn't that something your organization might want to promote?
Sure, yeah. And when ACPP, the American College of Private Physicians, we are built to support doctors in whichever version they might want. And some of our discussions are, hey, I'm doing this in my clinic now. It's working out well. You might want to try it in yours. But we don't necessarily say, hey, allopathic is the only way, or you should put PT in your clinic. We encourage and share information and connect resources together with other people who have done that or tried it and failed or tried it and succeeded. So that way everyone can get the flavor they want. But we don't necessarily promote or encourage a specific style of practice.
No, I didn't.
Practice the way they wish. Yeah.
Right. I didn't mean a specific style. I just meant expanding your, excuse me, if I'm a primary care, DPC and pretty traditional, but I understand I can bring other people in that can serve my patient population. Mm-hmm. How do I do that? Right. Yep. So I would go to your website, you talk with your group and you could help do that, correct?
Absolutely. Okay. A very common conversation we have is I'm starting a clinic. I want to set up a series of, I want to be a comprehensive care model for my patients. And it starts with a discussion like that. And we say, okay, well, hey, we've got these checklists. We've got these common things we think you might want to try out. We have some that sublease a room to an audiologist once per week, let's say. We've got some that have a plastic surgeon that comes in, and if that's the style of practice that it is, and they do like Botox injections and so on and so forth. We have some that have PT, the whole room dedicated to like you go there for a visit, you're also doing an exercise and things like that. We have some that also partner up with a gym, and there's a gym like in their building,
Sure, yeah.
and that's part of the care model. We will, if a clinic is willing to explore these opportunities, we will show them what a lot of others are doing, which models we've seen work great, which ones we haven't, and we'll hold their hand through the whole process, and we'll make introductions to other groups that do this.
Related, last question. I have right now, let's say I'm operating a traditional clinic, insurance, the usual, and I'm thinking of stepping out, becoming a DPC clinic, right? Is there what are the steps? I mean, I don't want to drop everything, right? I'm afraid if I lose my lifeline, all of a sudden we have no business. What do you recommend? Are there intermediate steps, or you can start doing something? I mean, how does that work? What would you counsel a traditional doctor that wants to get into this?
Yeah, so first off, we would typically do an assessment of their current practice, because the reality is they're going to build their DPC or concierge practice if they do decide to go that route off their existing patient population. The average statistic is 26% convert. Don't let any of the conversion companies tell you it's 50% or something like that. It's just not true. We've actually run the data. 26% is the average conversion rate. And of course, that's dependent on your pricing model and things like that. Either way, we love it when we get a full year to participate in a transition plan. Sometimes they call us up and they want to transition tomorrow, in which case you're kind of shooting yourself in the foot, because we can't sell your old practice. We can't transition them to another doctor that's going to pay you money, hypothetically, or an ACO or MSSP or something like that. And we can't give your patients enough time to convert into this other model. So we really encourage a group to pump the brakes on transition. If you give us a full year, we can show you how to do it yourself. That's the difference between us and a conversion company. We're not trying to make money on conversion at all. We just want you to be in the concierge and direct primary care space. We'll show you what's good, what's bad. It's your business, your practice, your livelihood. You built this. Sometimes direct primary care and concierge honestly might not be great for some doctors and some models. We'll let you know that openly. But if you do come into this space, we want you to thrive in it. We want you to be very successful. So it starts off with a big assessment. Then we migrate into, do you have staff that you just can't live without? Do you need to keep Susie Q and Little Mary employed? Like, would that just cripple you if you didn't do that? Let's create job roles for them. This is how this person can do this. This is how that person can do that. We connect you with lawyers to work through your non-compete clause you might have with the hospital or your other partners in your primary care clinic. There's a lot of checklist items that we go through, but time is the one that almost always is avoided. And the slower you do this, the better in most cases, because you want to give your patients the opportunity to transition. You don't want to hit them with a hard hammer. Hey, this is happening now. In that same context, we do find quite often that you give your patients a very good incentive to transition. And unless you're generating revenue from both your traditional practice and your now, let's say, concierge clinic, you offering that incentive, let's say like first year's $500 or something, you could hurt yourself financially quite a lot. There are lots of lending companies out there that'll give you plenty of money to start up your clinic. We work with one they provide the MSO. It's done through our group mostly. They give you a chunk of money to operate as a concierge doctor, and they hold your hand for the first 5 years. Like, that makes it a no-brainer to convert. But some clinics, for some doctors, that's just not going to work for them, that particular model. So take your time. That's my best advice.
Thank you. Charles Ford.
If I can answer my question, Jim. Charles Ford, if you can wait 1 second. I've always had follow-ups on these other questions. Let me share my screen real quick and just build on what you said about combining DPC with sharing. So Forbes magazine featured how we package sharing with either health savings accounts or DPC. There's a stupid government law that really makes them incompatible with each other for the time being until we fix that. or this money doubling account called a health matching account, which is great for folks with chronic conditions or facing an expensive event. And I'll put this in chat, how you can upgrade from insurance to sharing. One thing folks don't really appreciate is that Obamacare has networks, which exclude the best doctors you would want if you suffered a catastrophe like cancer or heart disease. Donovan mentioned the worldwide nature of sharing for his employees. That's a fact. When you're a cash patient, as long as the bill is in English and US dollars, that foreign expensive event is shareable. And as far as the HMA, John Goodman at Forbes featured also not just how we package sharing with the concierge, shopping assistant, and HSAs, but he also featured this money doubling account, which you can have with sharing and HSAs or DPC because it's a standalone product. This doubles your money over 3 years. So if you're facing a baby, birth, or braces, or an elective surgery, this is what you want. It's the best supplement for Medicare. It's the best supplement, period, because it's a cash account, so it's more expansive. And once you build your money over 3 years, $40 per month for 3 years doubles to $2,500, for example. It goes down to a maintenance fee per each month once you build that money. So that's a prepaid Visa. It's great for out of pocket. You got that. You got your DPC. You got sharing. You're paying total, $350, $400 a month, and you're bulletproof. You've got the DPC for 80% of your events. You've got the HMA for dental and electives and all this out of pocket stuff. You got sharing for catastrophic. So just keep that in mind. And I'll stop there, but you can reach me if you want to upgrade all your payment options. Donovan, any comment?
Oh, no, I mean, yeah, I see people going that route often, and that is a very smart method to do. It's smart to offer it to your patients directly, and it's smart to have it for yourself and your organization. It's also
You're muted, Jim.
much lower cost.
Charles Ford.
Just a couple of quick questions, and bear with me as I go through them. First off, who owns your company?
The American College of Private Physicians is owned by it's a nonprofit. There's a board operating it. I'm the CEO, but it's.
All right, so basically you're a management company that provides services for a doctor who wants to set up a DPC clinic. Am I correct on that?
As American College of Private Physicians, we are an organization that has membership-driven dues and things like that. ACP has a subdivision of managed services, which, yes, I also operate with my partner company.
Okay, and then my last question, we're running out of time, so I can't go down the whole list. My last question is, you have restricted membership to physicians. So you're restricting your membership and your board of directors to practicing physicians. Now that's a pretty narrow silo when you look at all the health options that are available, number one. Number two, I'll make the comment that you're still playing the game the same way in terms of burn, cut, and drug using the physician system we have in today's world. It would seem to me as an outside observer that you'd want to expand this to include non-physicians and alternative medicine.
Sure. Our board wanted to have physicians as the primary membership driving thing. So that's how that goes. But also there is some legal requirements in the private practice designation from the United States government on who can provide medical advice legally and everything else. From a attorney's perspective, that is a strongly recommended approach that we have physician driven first. But to add clarity to that, just because they're a physician doesn't mean they have to practice that physician way. Like, I'm a physicist by education and I'm not doing anything with physics, right? I'm doing this. So while yes, I would agree, it would be great to have nurse practitioners, RNs, or maybe naturopathic doctors involved in the process, working at it. The American College of Private Physicians has decided to have physicians as the primary membership driven. It's board driven, it's physician driven. It makes sense that they would promote physicians first and foremost. We will help out any group set up a clinic and maintain the clinic however they see fit. But part of a core benefit of our membership is that we credential and that's it. We credential, we create reference listings for the doctors. So we check the National Provider Data Bank. We check their malpractice logs. We check their Office of Inspector General. We go through all these checks and balances to say, these are physicians that are legitimate on paper for sure. And we've had an interview with them. We know that their model or their history is good. Does that prevent other people that are non-physicians from working with us? Yeah, I would agree, but it's not all cut and burn. We have a full spectrum of physicians at our organization. We've seen every flavor of concierge and direct primary care you can imagine. We have some that just do everything through painting and yoga. And we have some that are just doing like mental health therapy care. It's a psychiatrist running a concierge clinic. And we have some that are highly interventional. Like we're doing an MRI every year. We're doing a heart flow process through it to determine where atherosclerosis may surface in the future. And we're putting clarifications in those areas to make sure that you don't calcify and get any need for stents or anything else. We've got all versions and we encourage all versions. But in our model, it does have physicians. You are correct, Charles.
All right.
Thank you.
Yeah.
So we're coming up on the hour. Anyone have a last 1-minute question before we wrap up? Going once, going twice? Okay. Donovan, why don't you tell people how you can be reached and or followed?
Yeah, so you can always go to the American College of Private Physicians website. I'm putting it right here. You can go to our store, you can go to the membership, you can go to the contact us page. There's lots of contact information on there. By all means, try to reach out to us through there. The info@ACPP email that goes to our team that helps out with this process. We also have a phone number. You can call it 24/7. Someone should be there to help you out, or our call center will support you and make a message, and then someone will engage you later on. But we really want to see everyone enter this market and thrive into this market if they so please. And we're going to help you through that journey.